A very good evening to all. First of all, let me thank Dr. Jyotidev, Dr. Ms. Sunita, Arun Shankar and the whole JPEF team for giving me another chance. And this evening, in fact, I am very much privileged to chair a session that's going to be done by none other than the senior most, probably endocrinologist in Kerala, and the current director and CEO of Indian Institute of Diabetes, Dr. Jabbar. And we are going to have a very enlightening session on second generation analog insulins. And just adding a sentence, we are living in a country where almost 60 to 70% of people are even, for them, even human insulins is a luxury. And when we talk of say analogs, the majority of our population is not at all reachable at all. But fortunately enough, now we are having molecules. Now we are having preparations that are cost effective and that are affordable, and that could be used in the probably in the middle income group as well. And one of the molecules that Dr. Jabbar is going to talk about comes under such category, and I am sure we are going to have a very enlightening session. Over to my co-chairperson.
Thank you. So good afternoon. Now the session will be on precision insulin management, maximizing generation 2.0 basal insulin across patient population. Dr. P.K. Jabbar will be speaking to us. And it gives me great pleasure to introduce Dr. P.K. Jabbar, who's an endocrinologist practicing in Tiruvandanapuram. He is DM from KEM, which is Mumbai, which is where I am from. And so I must, though he has a very long introduction, but I think let's keep the introduction short and let's listen to him. With this, you must.
Good evening all. Respected Chair and Senior Most, one of the Senior Physician, Dr. Mohan Nair, Dr. Purohit, Dr. Titus, Dr. Bas, senior members of profession, colleagues, friends, ladies and gentlemen. I am extremely excited here because of two reasons. Once again, I got a chance to attend JPEF. My association with Dr. Jyotidev starts from 1995. And my session is chaired by one senior person and very close to me because of two reasons. One, if you see the history of Indian Institute of Diabetes, the main design is done by Mohan sir. Now it's came to a reality. Now we have a beautiful center. So sir has taken a lot of effort to prepare that project. And secondly, this session is a sponsored session by Sanofi. And I'll be discussing it's not a new molecule, it's a very common molecule, I would say. And most of the physicians are having a lot of experience with this molecule also. My plan is here, very simple discussion. I don't want to take a lot of time here. My dear friends, you should see Lancet Diabetes Endocrinology published last year. There is no boundaries for diabetes. Diabetes is becoming a pandemic issue. If you see the data, ICMR data, we have maximum patient of diabetes mellitus. And a small state, you know Goa? Goa, we have maximum number of patients with the diabetes mellitus. And Kerala state, we have lot of patients with hypercholesteremia. Hypertension is 43%. Obesity is 45%. Central obesity again 45%. My dear friends, we are in real danger. Please remember that. Try to do something for that. That's a message. This is the data from Kerala state, a part of ICMR. Just read the red line. Diabetic prevalence is around 25%. Yet another interesting phenomenon, just compare what is happening in rural area, what is happening in urban area. There is no difference. So we are all becoming rich in terms of health as well as in economy also. My dear friends, high time to act, please remember. Now, if you look into the reality, the diabetics management is starting from non-pharmacotherapy, which never happens, that's my view. And if you look into the glycosylated hemoglobin of our patient, what is the target? Target is 7% as per the standard document. But if you see the data across country, very, very few patients are getting good glycosylated hemoglobin. This is one study they have included just north, south, east, west. Everywhere, diabetes control is very, very bad. That is the only take-home message. And 4 out of 5 is true. Around 70% of the patient, they are not getting good control on diabetes. And very few patients, less than 25% of the patient, they are taking insulin as a treatment modality for this patient. And average glycosylated hemoglobin, I have a correction for this slide, probably little more than that. But average, as per the document, is 9.2% of glycosylated hemoglobin. And they included pretty good number of patients, around 6,236 patients. In continuation with the data, we have at least 4 more data are available. DABCAT data, TIE trial, CAS trial, and other studies also available. Everywhere, the carrier message, take a message, important message is uncontrolled diabetes is also becoming a pandemic issue, my dear friends. Now, this is my own data. Initially, I thought I should not present this data in front of Kerala people. But reality we should understand. I think Titus sir try to act. Okay. So we have good control. What is the percentage on the left side? What is written, sir? 24.6% only. And fair control, not happy, but okay, chalega. That patient's around again 35 to 40%. And very poor control happening in good or sizable population. That is a ground reality. Now, let us come to the management of diabetes mellitus. You can see the data from rural and urban. The green line is for insulin. See here, everywhere, even the urban area, rural area, only 4% of the patients they are taking insulin as a treatment modality for diabetes mellitus. These are the ground realities. Please remember. Now, insulinization in India, what is happening? Again, the same message. Only 30% of the people with diabetes mellitus is getting or treated with insulin. And around 50% of the patient, they are going for delayed insulin treatment. If I remember certain data, something like legacy effect of diabetes. When I was a student at KM Hospital, it was 10 years. After when I became assistant professor, it came down to 5 years. Now what is the data? Initial first year of your diagnosis. That's the first anniversary. That is the most important time where you should attain or you should get a good control on diabetes mellitus, which is almost impossible. But this data showed around 50% of the patient, whatever be the reason, maybe physical problem, social problem, financial problem, whatever the problem, eventually patients are not getting insulin at appropriate time. If you take the probably old data, 5 years, 10 years of legacy effect, people are not taking insulin at appropriate time. Then you will ask me, at least students will ask me, what is the best time for starting insulin? Best time, as per the beta cell physiology, Starling law of beta cells, if the blood sugar crosses more than 180 milligrams per deciliter fasting, you should start. That is the data, but of course that is not possible also. So what are the consequences of this delayed insulinization? Lot of consequences you can see here. The blue lines less than 7. So if the patient is getting good control, whatever be the method, maybe insulin, maybe oral hypoglycemic agent, if you are getting good control in the initial phases, definitely you can reduce lot of diabetes related complication, both micro as well as macrovascular complication. Now, let us explore further. What is the inertia here? Just now, Dr. Sasank and Banshi and their team was discussing about the physiological or psychological insulin resistance situation. Such a common problem. So you can divide it into two: patient's problem and health professional issues. So what are the issues? But for an average physician like me, I'm just worried about hypoglycemia here and weight gain. These are the very important complications of insulin, and we want to avoid this complication in our clinical practice. That's our plan. Now, so you take the history of insulin evolution, I would say, and insulin treatment, again, there are two types. There are something known as basal, and another set of insulin preparation is prandial insulins. And of course, the basal insulin, if you take the history is like this. You have NPH insulin somewhere in the independence time, 1946, and subsequently you got lot of insulins, like detrimer came, glargine came, and modification of glargine also it's available now. So what is happening with the pharmacodynamics? Pharmacodynamics, NPH is not acceptable, I would say, but see, if you ask the opinion of Dr. Amesh Nair, he will tell, okay, his experience is very good. But precisely speaking, the current profile of NPH in insulin is not acceptable. See, these patients are likely to develop hypoglycemia at the peak time. So that's evolution. That's the importance of good basal insulin. If you go for glargine insulin, there is no peak. It's a peakless insulin. And eventually hypoglycemic episodes are less. And this was 100, and you have another insulin also came up, but simply disappeared from the market. And you have insulin degludec, and second generation glargine 300 is also available. See what is happening here. 300, it's a very flat one. There is no chance for hypoglycemic episodes. And even the weight gain is also significantly reduced with the newer generation glargine insulin. Now, this is most important for us, hypoglycemia. If I am quoting words of great teacher Dr. Minu Hariharan, madam used to tell us, don't produce a hypoglycemia, my dear student. If you are producing a hypoglycemia, that patient will go for diabetic shopping. So hypoglycemia is the most dreaded complication. Another data shows if the patient develops a hypoglycemic episode, these patients are likely candidates for vascular insult in near future also. So at any cost, we should not produce hypoglycemic episode. And of course, there are the ideal molecule for the treatment of type 2 diabetes mellitus. Glycemic variability should be reduced. Very good control. No weight gain. Target organ is protected. At least these are the basic requirement for a insulin molecule. But I know this elegant team, you wanted to get some sort of evidence-based medicine. That's the reason we have added a lot of evidence, or the classical evidence-based medicine. Now, if you take the efficacy of this second generation glargine, what's happening here? This is the glargine 300, and compared to 100, you can see here the glycosylated hemoglobin. On the other side also you can see what's happening with the glycosylated hemoglobin also. So what is the take-home message here? Take-home message is, try to get good glycemic control without hypoglycemia. If you take the hypoglycemia, especially, we are much bothered about nocturnal hypoglycemia. The importance of the recent glargine molecule is nocturnal hypoglycemia is significantly reduced, drastically reduced. That is exactly, that's your aim as a physician. You wanted to avoid hypoglycemic episodes. See, in total, hypoglycemic episodes are significantly reduced, both incident as well as confirmed hypoglycemia, and nocturnal hypoglycemia was significantly reduced in this study. That's a take-home message. Now, coming to certain group of patients, like CKD renal patients, and you have geriatric patients also, what will happen with this molecule? I don't want to discuss a lot with these slides. See, at least you have 4 studies which is depicted here with the improvement and efficacy of this molecule in terms of glycosylated hemoglobin and episodes of hypoglycemic episodes. You can read the details of EDITION trial, ATOS trial, BRIGHT trial, and TAILOR trial. everywhere it's written. It's a very positive and very comfortable study which showed, see, you can get good control of diabetes mellitus without producing even a single episode of hypoglycemic episode. That's the importance of this. Now, this is the continuation of BRIGHT study. You can see here the glycosylated hemoglobin basal value, and after some time they could document significant reduction of glycosylated hemoglobin. It seems a very good molecule for reducing glycosylated hemoglobin. This is another method of looking into that. If the patient has got renal impairment, see, very safe. Glycosylated hemoglobin reduction is also there, and patient is getting good control or glycosylated hemoglobin control, you can see here. Now, you have certain data which are coming from Europe also, and incidence of I wanted to emphasize for hypoglycemic episodes. Incidence of hypoglycemia was significantly, drastically reduced with the second generation glarginins. Now, you have another data also. Delivery data is also available in the literature. There also it showed those who are having renal impairment, the hypoglycemic episodes were not significantly increased, and in fact it was reducing also. Now this is again elderly patient, less than 70, more than 70. In both these two group of patient cohorts, it was showing significant improvement in terms of glycosylated hemoglobin and episodes of hypoglycemia. So lesser hypoglycemic episodes in delivery 3 trial also. You can see the data here everywhere. What is shown here is glycosylated hemoglobin reduction and hypoglycemia. Conclusions of deliver 3 trial, very simple. Hypoglycemic episodes, it was very encouraging in terms of hypoglycemic episodes, and what is not shown here as a weight gain was not very significant, and glycosylated or efficacy of the molecule is also very, very encouraging one. And this is yet another way of looking into that. If you are using 300 and 100, so everywhere, so hypoglycemia is not an issue, confirmed hypoglycemia was not an issue, and very importantly, nocturnal hypoglycemia was not there with the second generation glargine insulin. Now, coming to the type 1 and fasting, see, this is the glycemic variability. What is shown here, the green one is glargine 300 and blue one was IDAC, and you can see here glycemic variability was less or minimal excursions of glycemic profile was documented in this study. This is again with the CGM, what it showed, the glycemic variability was good, or in fact was improving, the excursions were significantly reduced with the classical drugs. Now this is the data again showed the reduction of nocturnal hypoglycemia, and this glargine 300 improves the glycemic variability irrespective of injection timing. That's also very important, especially if the patient goes for Ramadan fasting all those time. This glycemic variability excursion will be a real problem, and they can go for hypoglycemia. Sometimes they have to break their fasting also. So what is shown here in Orient data is during Ramadan time. So what is shown here in the less than 7, it's only 2.6%, 74 milligrams, and less than 54 milligrams, that is severe hypoglycemia, never happened in this Ramadan fasting cohort. My dear friends, ladies and gentlemen, but I want to tell you that this drug is not producing significant number of hypoglycemic episodes. Now, adherence. Ramadan fasting, people think that if I am getting a good molecule, I am very happy to take that without producing hypoglycemia. And this survey showed people are very happy with this glargine 300 molecule. Now coming to the inpatient also, which also showed glycemic variability was reduced, and they were getting good outcome in terms of hospital stay and complications related to diabetes. Coming to the pregnancy and the glargine 300, yes, you have green signal for using that. DCGI 2018, it said you can use it, and I think Europeans, they started using glargine insulin in good number, so I think there is no much concern for using this type of insulin for our patient. Now coming to the second part of my discussion, insulin delivery. It's a real problem. patient doesn't want to take insulin because of many reasons. Maybe a patient-related problem, and they think that, say insulin is the final answer for my disease, and I will die within no time if I am taking insulin. Some sort of myth is there. And among the physicians also, my dear friends, they feel that, see, I want to get a good molecule or insulin molecule without pain or pain of injection. So that's the thought process of our physicians, and we have good delivery devices with this type of newer molecule, and seems to be very comfortable, and pain of the injection is very less, and the loss is less, and definitely is cost effective also. And this is snapshot view. You can see lot of studies you have, combination with oral drugs. GLP, you have 2 studies here, and probably 1 dozen of studies are available in the literature in terms of efficacy and safety of this molecule. This is again, see the issue of hypoglycemia, very low risk, definitely GB is coming down, hospital patients you can use, pregnancy, yes, and elderly patients, definitely you can use it, and CKD patient and type 1. What more you want? So I think, see, this molecule has got its own role or space in the management of type 2 diabetes mellitus for a good control, good compliance, for reducing hypoglycemia and for reducing glycemic variability. That's all from me. Thank you very much for the attention, ladies and gentlemen.
Thank you, Dr. Jabbar, for the excellent presentation on this new molecule. Any comments too?
At least your title sir will ask us question, right?
Anybody would like to?
Sir, see, flexibility definitely flexibility is there for newer glargine and IDAG also. There is no doubt. Of course, numerical difference will be there. Okay, and people are, see, these are all studies. That's all. Yes, sir, please.
Which district in Kerala has got the highest number? Which district in Kerala has got the highest number of...
Trivandrum. No, because, see, we took the survey from all 14 districts. Okay. What is noticeable here is there is no difference between urban and rural area. That's a very important issue. You go to Tamil Nadu. Tamil Nadu situation is slightly different, right? Okay, there is definite difference between urban prevalence and rural prevalence. In Kerala, nothing like urban, rural. Everywhere urban only. Okay, that's very important. And what is the exact cause of this urban and high prevalence of diabetes? It's a very tough question to answer. In fact, the principal investigators of this study, Dr. Mohan, ICMR, and our team, we were examining all those things. To be very frank, we did not get any definite answer for that. Like, so rice eating. You are also eating rice. I am also eating rice. And probably color of the rice is slightly different. But there are studies say that the white rice is good. There are studies say the white rice is not good. So, a lot of conflicting data. But satyam bole nilkunnu, that is, diabetes prevalence is very high.
Regarding hypoglycemia, is it comparable with degludec or safe or non-inferior?
No, I think it's more or less same, slightly better, that's all. Highest incidence in Goa. Sir, basically, this study is for age more than 18. Okay, and usually type 2 only. Genetic analysis for type 2 diabetes mellitus is extremely difficult. They wanted to do some study for that. Like, type 1, yes, you can. Type 1, see, highly heterogeneous and complex disease. So, what I understood from the literature and from the discussion by my team is difficult. But, sir, there are some issues are happening. That's true. Yes, sir.
Definitely there is an inertia on the part of the physicians as well as patients to accept the insulin regimen. And in the hospital, always we had to have an insulin infusion, especially in emergency situation, followed by basal bolus regimen. What I want to ask is, the Glargine insulin 100 has got 24-hour action. Most of them may have 20 hours or 22 hours. The pre-dinner value will be high. Whether this 300 will cover the 24-hour action, just like Degludec.
Sir, Bargon sir is a very senior physician. Probably he might have seen a lot of cases than me, there is no doubt. But you see, all these newer agents, it's not truly 24 hours acting, there is no doubt. But diabetes management, not with the Lantus only. There are other molecules also. So in practice, clinical practice, we are getting almost 24 hours of action. No doubt, because you are taking some other molecules also, not only Lantus. You are taking other oral hypoglycemic agents, other issues. So I think in practice you are getting, and there are physicians, they are giving 2 jabs of Glargine also. I have seen a lot of prescriptions, probably because of this reason.
Dr. Jabbar, the title is precision medicine. So what is precision or personalized in your talk?
Sir, don't ask me tough questions. Okay, certain questions is very difficult to answer. Okay, thank you. Yeah.
So anyhow, that was a wonderful presentation, and probably Dr. Jabbar will agree that the charm of this new molecule is that even for a person who is taking Lantus or Glargine 100, the total quantity that has to be injected is very low when you compare. In fact, that's almost 1/3 of what you are taking for in terms of quality, because 1 ml of this molecule, this preparation contains 300 units, whereas 1 ml of the other preparation contains only 100 units. And in terms of cost also, this second is more affordable than the Glargine. So even for people who are on Lantus, probably this one is a better choice. So if there are no other questions, thank you very much for the patient listening. Thank you.
Thank you, Mohan sir, once again. Thank you, Purohit.